Well, hello everybody. This is Chris with the Ancient Scholar. So today I'm doing something very different. I'm actually going to be annotating um, a PowerPoint, or rather a keynote presentation, because this is actually all of my videos and all of my presentations are done on Apple products, either Macintosh or iPad. So I'm using Keynote, and I thought what I'd do is just try something very different and new, just to try to add a little variety to what I do at the Ancient Scholar. So today I'm going to be talking, transitioning from the introductory topics that I talked about last week, and that is basically deciding who needs to be on mechanical ventilation and then actually initiating mechanical ventilation. And now we're going to move on from initiating mechanical ventilation to actually managing somebody on a ventilator and managing the ventilator settings, and we'll just kind of do a basic overview today. So, again, we're just talking about the phases of ventilator management. We just finished talking about phase 1, and that's the initiation. And phase 2 is what we're going to talk about today. It's kind of an overview, talk about changing some of the major settings to meet patient demands, or to change settings in response to abnormalities in oxygen, ventilation primarily, and then some basic troubleshooting. And then phase 3 is actually the liberation, which they often call weaning and extubation. I prefer the term liberation because it's a bit more all-encompassing and really emphasizes that our priority should be to get the patient liberated from that ventilator, breathing on their own. So we're on the ventilator. Now what do we do? Well, just some general principles. We need to check that ventilator. In just general rule, we need to check that ventilator at least every 2 hours. We need to do a physical examination as soon as a patient goes on the ventilator, and that's the inspection, percussion, palpation, auscultation exam that they teach you in respiratory school. And we need to do vital signs every 2 hours, and we do this physical exam and vital signs assessment with the ventilator check. Also, as I talked about on the last video, you need to get an arterial blood gas drawn and analyzed within 30 minutes of initiating mechanical ventilation to get a baseline of where our patient is and to see what kind of changes we need to make. And then, of course, at some point we need to get a chest x-ray as well. Okay, so some of the general principles of ventilator management. Again, ventilator checks at least every 2 hours. Good oral care, and this is probably something that's often underlooked in respiratory care. We want to do very good oral care because we get lots of secretions. Our patients are often not able to handle or manage their secretions. They get a lot of secretions. You know that the mouth, the oral cavity, is pretty much a polymicrobial breeding ground, and aspiration or microaspiration of secretions can lead to a ventilator-associated pneumonia, nosocomial pneumonias, infections, and so on. So we want good oral care. Good suctioning, and I did put PRN, and that's as needed. We should never have suctioning on a schedule, and that is we should never order suctioning say Q2 or Q4 hours. Suctioning is really a function of what's going on with our patient, and if there is a indication for suctioning, then we should suction. Otherwise, we don't necessarily need to be suctioning. And then I have this inline setup as if needed, a question mark, and oftentimes we'll arbitrarily put an inline, what they call one of the trademark setups is very popular, excuse me, very common, is known as a Ballard suction unit, and that basically is just an inline unit that goes in the ventilator circuit itself, and you don't have to disconnect the patient from the ventilator to suction them. This is very nice because it decreases a risk of cross-contamination, both introducing foreign contaminants into the patient and exposing the providers to contaminants from the patient. So this works both ways. It also maintains a pressurized system, and there are certain patients that are highly dependent on PEEP for oxygenation, and every time we disconnect the circuit and suction them, of course, we risk potential de-recruitment of alveoli, so that's nice. Heat and humidification. Oftentimes in the emergency room, patients will go on the ventilator and a heat and moisture exchanger, an HME, will be placed. Really, an HME is kind of a short-term heat and humidification device. It does not provide 100% body humidity, nor does it provide the appropriate amount of heat. So generally after about 24 hours, we need to look at changing that HME out to a proper heat and humidification system. Generally this will be a cascade system on modern microprocessor ventilators. Also, the question they like to ask on board questions is you have a patient who's on a ventilator, the HME's been attached, they've been there for a day or two, and they've developed thick tenacious secretions. What do you do? Well, this is pretty much a classic finding of insipated secretions, and of course they're becoming dry. The mucociliary transport mechanisms of the airways are failing to get rid of those thick tenacious secretions, and we need to provide heat and humidification. So we need to get rid of that HME and transition to a proper system, a cascade system. Head of bed elevated 30 degrees. This is going to depend on a lot of factors, hemodynamic status, and so on and so forth. But if we can, we'd like to. Again, this has helped to decrease the risk of microaspiration. Even though I do have a endotracheal tube placed in the trachea and a balloon inflated, we really need to be very cognizant that I can still develop microaspiration around that tube and develop pneumonia. Another thing I'd like to add is the cuff pressure check. We should be doing that at least a couple times a shift as well. We want to keep our cuff pressures, ideally in the 20s, certainly no higher than 30 or 35. Simply because we can cause tracheal ischemia and possible necrosis if our cuff pressure is too high. This is a VAP bundle, and if you're not familiar with the term bundle, you certainly will be here fairly soon. Basically what this is a bundle of interventions that are required on every ventilated patient. A lot of hospitals have gone to these bundles to try to prevent pneumonias, and of course these bundles include interventions like elevating the head of bed, good oral care, so on and so forth. High-low endotracheal tubes that can suction around the cuff and things of that nature. A VAP bundle is a ventilator-associated pneumonia bundle, not uncommon to see on ventilated patients. And then circuit changes. Circuit changes are going to kind of vary from facility to facility. If the circuit becomes obviously soiled or tainted with secretions or some sort of foreign matter, clearly that circuit needs to be changed out. Okay, so what do I do on a ventilator check? Well, there are a lot of things I monitor, obviously, with the placement of the tube, the cuff pressure, my IPPBA assessment. I'm also going to assess the peak inspiratory pressure. It's under monitoring airway pressures, and then I'm going to assess the plateau pressure. If I'm in pressure control ventilation, the plateau pressure is irrelevant. I won't be able to assess it, but in volume control, definitely assess the PIP and the P-plat. And of course, from that and the PEEP, you can also do a static and dynamic compliance. It's a compliance dynamic and compliance static, the C static and C dynamic calculations. Okay, so let's just talk real quickly about the PIP versus the P-plat, and I actually had a video where I covered this, and I linked that video to the first playlist on introductory mechanical ventilation. But basically, if you look over here, I know I haven't gone over ventilator graphics, but this is one of the graphics. This is called the pressure time scaler, and this is a waveform. And basically on the y-axis, the vertical line, if you look in the upper left corner, the vertical line up and down is pressure, and then the horizontal line, the x-axis, is time. So this is basically making time a function of pressure function of time, depending how you look at it. So the peak inspiratory pressure, the PIP, if you look at that one that says normal there on the left, is the highest pressure encountered in the airway upon delivery of a breath. So we're talking about inspiration. So it's the highest pressure, and you can see it there as a little peak. And then what I do is I do something called an inspiratory hold, where I just hold it for a little bit at the end of inspiration. And what that does is that actually measures the pressure in the alveoli themselves. This is always going to be lower than the PIP. And generally the PIP and the P-plat will go together. They should correlate well. When they don't correlate, well, there are actually two criteria. When you see the peak inspiratory pressure elevated, if it's elevated, it's above 30 to 35, you need to find out why it's elevated. And PIP can be elevated for one of two reasons. High airway resistance, and this would be things like mucus plugs, my endotracheal tube's too small, my tubing's kinked, I have a mucus plug, bronchospasm, and secretions in the tube, and so on and so forth. If this is the case, the PIP will be elevated, but when I do the plateau pressure is going to be much lower than the PIP. So there will be a very big difference between the PIP and the P-plat. And that difference, that delta P, is actually indicative of airway resistance. There's a lot of resistance there. And hopefully that makes sense, that if the P-plat is a pressure in the alveoli, well, if the problem is with a plug in the endotracheal tube or bronchospasm or something on that lines, then it makes sense that the pressure in the alveoli is not going to be particularly high, because our problem isn't in the alveoli. So you can see the P-plat on the high RAW, or airway resistance. RAW is resistance in the airway. You can see the P-plat is much lower than the PIP. This is classic for an elevated airway resistance. However, if my PIP is elevated and my P-plat elevates right along with it, and you can see on the bottom right there the low compliance, both the PIP and the P-plat are elevated together, and there's very little difference between the PIP and the P-plat. This indicates a lung parenchyma problem, or an alveolar problem, to be more exact, an alveolar lung compliance, chest wall compliance as well, in some cases. But generally we're talking about within the lung itself. This can be things like ARDS, pulmonary fibrosis, possibly circumferential burns of the chest, and so on. I would like to say that every picture in this presentation I took myself, with the exception of this picture down at the bottom. You can see I've linked the reference for that picture, just because I thought it was a really good picture. Okay, so again, this is just something that I've already talked about. We talk about large delta between PIP and P-plat. We're talking about RAW, lots of things. Mucus plug, secretions, small endotracheal tube, a kink tube, bronchospasm. If the PIP and P-plat elevate together, this is a decreased compliance issue. We're talking about ARDS, pulmonary fibrosis, circumferential chest wall burns, pulmonary edema. With that, you could put, large pulmonary infiltrates, abdominal compartment syndrome, and circumferential chest wall burns. I think I repeated myself a little bit there, but these are just some things that can cause elevated airway resistance and versus decreased compliance. Okay, so let's talk about some of the general problems with ventilation. Now, if you remember back from pulmonary anatomy physiology, ventilation is the movement of gas in and out of the lungs. This is primarily measured by carbon dioxide. So if I have a problem with ventilation, I have a problem with blowing off carbon dioxide, getting rid of CO2. So if I'm in volume-controlled ventilation, these are the things that I can do to blow off more CO2. I can increase, ultimately, I have to increase the minute ventilation, my VE. If you remember, the formula for VE, minute ventilation, is rate, is a product of rate and tidal volume. So what can I do? Well, I can increase my rate, or I can increase the volume. Generally, you want to start off with rate and then increase volume, because we know that volume can impact airway pressures, specifically the plateau pressure. So increase your rate and then increase the volume. You want to watch for increased airway pressures, and auto-PEEP can result with increased rates. Now, if I'm in pressure-controlled ventilation, I now don't actually have a volume, but what I can do is I can increase my peak pressure, because I actually set my PIP. So if I want more volume in pressure-controlled ventilation, I have to increase my PIP. And that's exactly what I said down there, is PIP equals tidal volume. Higher PIP, higher tidal volume, lower PIP, lower tidal volume. Again, I want to look at increasing the rate first, and then move on to increasing the peak inspiratory pressure. Again, attempting to keep my pressures as low as possible. This is the formula for minute ventilation correction, and this kind of gives us an idea of what our new minute ventilation should be. So the formula, if you look on the left, the new minute ventilation is going to equal my current PaCO2 multiplied by the current minute ventilation divided by the CO2 that I want. So let me give you a scenario. Let's say that our CO2 is 50. Our current minute ventilation is 5 liters a minute, and we want to blow that 50 down to 40. What would our new minute ventilation need to be? So I put 50 millimeters of mercury as my current, 5 liters per minute as my current minute ventilation, divided by what I want my CO2 to be, 40 millimeters of mercury. So I'll do 50, first I'll do the top, 50 multiplied by 5. That should give me 250. And then I simply divide 40 into 250. I can go ahead and knock out a 0 there, and that's 4 into 25, and that should give me 6.25. So my new minute ventilation will go from 5 liters per minute up to 6.25 liters per minute. Okay, problems of oxygenation. So when we talk about oxygenation, this is primarily going to be assessed with my saturation, my PaO2, and all the different measurements I can use for oxygen delivery, diffusion, and so on. In volume control ventilation, the primary intervention for increasing oxygenation is PEEP. Positive end expiratory pressure. PEEP increases the functional residual capacity. It increases the alveolar capillary membrane surface area and allows for improved diffusion of oxygen across the membrane. I want to increase my PEEP first and then look at increasing the FiO2. If at all possible, I'd like to keep my FiO2 under 60% or 0.6. You can also, if this is failing, you can also consider an inspiratory hold, and we talked about doing that with a plateau pressure where I actually prolong my inspiratory time a little bit. I can also do decrease my flow. If I decrease the flow, this will increase the I time. And I may consider something called inverse ratio ventilation, where my I time is actually longer than my E time. Clearly, this can lead to lots of problems, such as auto PEEP, such as hypercapnia or carbia, elevated CO2, ventilation problems, respiratory acidosis. So I need to be very careful if I do inverse IDE ratio of ventilation, and I'll probably talk about that a little later on, since it is a specialized mode. And generally, it occurs in pressure control. Okay, now if volume control ventilation fails to work and my pressures are high, my lungs are non-compliant, I need to move on to pressure control ventilation. In pressure control ventilation, the ways I improve oxygenation is by increasing the PEEP. I can also increase the I time. Again, this will decrease flow of gas and prolong the I time. I want to be very cautious with the increasing in FiO2. I want to keep it under 60% if I can. Clearly, if I have to go higher, I have to go higher. And then if all else fails, I want to consider specialty modes of ventilation, such as bilevel, airway pressure release ventilation, high frequency oscillatory ventilation, and so on and so forth, such as high frequency jet ventilation and all these other advanced modalities. You see the picture on the right is actually a picture of a high frequency ventilator. This is actually something that we won't talk about until next semester, but I'll go ahead and just kind of give you a heads up now, and I'm sure you've talked about it a little bit in your physics class when you talked about the physics of high frequency gas flow. Okay, this is the FiO2 correction formula, and what this is what I do is if I have a patient on a certain FiO2 and they have a certain PaO2, and I want to adjust that PaO2 up or down, this is a formula that I use to do it. It is nothing more than a dimensional analysis, a very basic dimensional analysis. So on the top, I put my current PaO2 divided by the current FiO2, and that equals the desired PaO2, or the PaO2 that I want, over X. And of course, X is going to be the new FiO2 that I could set my ventilator up, and that new FiO2 will get me the desired PaO2. So let's say that our patient has a PaO2 of 300 millimeters of mercury, okay? At 300 millimeters of mercury, and their FiO2 is 0.8 or 80%. That's the current FiO2. And I want to get their PaO2 from 300 down to 90. And I want to know what FiO2 would it take in this situation to get that PaO2 all the way down to 90. This would be a pretty drastic change, but this is just something to show you kind of how the math works. So I'll go ahead and put 300 millimeters on top. That's my current PaO2 divided by my current FiO2, 80%. That equals my desired 90 millimeters over X. Now what I do to solve this is just a simple dimensional analysis. I go ahead and cross multiply both sides. So I'll go ahead and cross multiply. 300X will equal 80% times 90. So 300x equals 7,200. Now this has just become a basic linear algebra problem. I want to go ahead and get x all by itself, so what I'll do is I'll divide the left side by 300. What I do on the left, I have to do on the right, so I'll divide the right by 300 as well. So let's go ahead and divide the left by 300. So 300 and 300 cancel out, which means x is all by itself. The equal sign falls down, and then I simply divide the right side by 300. I can knock out the zeros, and 3 goes into 72 24 times. So my new FiO2 would be 24%. Okay guys, this is just a quick introduction. As a friend of mine says when he's teaching patients, he's a nurse, when he teaches patients about their conditions, he says, you know what, I'm going to give you the Reader's Digest version of what's going on here. To try to distill it and to keep it simple, and that's exactly what I've done with this this video here. Again, this is a very basic introduction, just to give you some things to think about, some formula to think about, and as the week progresses, I will be doing additional videos. Okay, guys, thanks for hanging in there.